Brisk budding, what next in girls? What is the last thing in puberty? Hair, then growth spurt, then menarche. Right? That's the pattern. So here you need to know girls attain puberty earlier than boys, but the final height may be different. So the second abnormality also. So in that case, this age bowing is very common. So the likely diagnosis is physiological bowlegs. Three best of five MCQs like this. One is bowlegs, abnormal biochemistry, abnormal leg strain. Then diagnosis is rickets. Second type is bowlegs, normal biochemistry, abnormal leg strain. That is metaphyseal dysplasia. Third variety is what I have given here. 2 years, bowlegs, normal biochemistry, normal leg strain. That is physiological bowl. Right? So three conditions can come in differential diagnosis. What is this? Repeat. Okay, repeat. So bowlegs, normal biochemistry, normal X-ray. That is physiological. Biochemistry means not biochemistry department, biochemical investigations, right? So that means normal calcium, normal oxalate, normal phosphate. So then bowlegs, abnormal biochemistry. That means biochemical abnormalities are there, but X-ray is also abnormal. Abnormal biochemical test, abnormal X-ray. So then that is rickets. The third variety is X-ray is abnormal, but biochemical investigations wise normal. That is metaphyseal dysplasia. So the same question, I would have given you three best of five MCQs. So these five answers are the same, but the statement would have been slightly different, right? Okay. A 5-year-old boy presents with ataxia for 1 week duration. He has early morning headache and vomiting. What is the most important examination finding which would aid the diagnosis of underlying condition? Now, this we all know this is a case of brain tumor, right? Most of I think right. Most of these are uh, brain tumor, clinical features of brain tumor, right? But presence of cerebellar signs, okay, it may be there, may not be there. I mean, exaggerated reflexes could be due to anything. Even anxiety can have exaggerated reflexes. Upward planta, even due to demyelination disorders, upward planta can be there. Sensory level is not I mean, you can't take that. So papilledema is a thing. So the other, so this is a case of increased intracranial pressure. So I mean, cerebellar signs can be there even in drug intoxication. Exaggerated reflexes may be there in anything. Upward planta is a feature of upper motor neuron sign, but upper motor neuron signs are not always due to space occupying lesions. Even demyelinating disorders, things like multiple sclerosis, not in children. You call that condition as ADEN. So in that case, the papilledema is the answer. So this is a very common case these days in the ward. Those who did pediatric recently, they have noted how many children presented with diabetic ketoacidosis. So a 13-year-old boy presents with diabetic ketoacidosis. His initial blood glucose level was high. After 8 hours of standard therapy, his blood glucose is 200. His blood gas after 8 hours revealed persistent acidosis. So child is having persistent metabolic acidosis, but blood sugar has drastically dropped. So what is the most appropriate management step at this point? um, so so persistent acidosis means child is having ongoing ketogenesis. So our aim in diabetic ketoacidosis is to suppress ketogenesis. So to do that, we have to continue definitely insulin. But what will happen if you continue insulin alone? This blood sugar will further drop down and child will go into hypoglycemia on ketogenesis plus hypoglycemia will be the entity. Because of that, we will have to give dextrose plus insulin together. So then the answer would be uh, da, 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 yeah, answer D, continue insulin infusion while adding dextrose into the intravenous fluid. You might have to add even up to 10% dextrose, right? So in the past, it was very difficult to convince nurses because they might think that you are going to kill this child with diabetes mellitus, this doctor is going to give dextrose, Travish, right? But that's not the case. Nowadays, we all know this has to be the appropriate management because in the past, people tend to drop down blood sugar level drastically, and that will end up in cerebral edema. Right. Another pediatric emergency. A 2-year-old girl presented with hepatomegaly, generalized lymphadenopathy, and splenomegaly. The diagnosis was made as acute lymphoblastic leukemia, and decision was taken to transfer the child to Paediatrics Hospital, Maharagam, Cancer Institute, Maharagam. So, what's the most important management of this patient before transfer? All these management options are correct, but the question is what is the most important one, because child might not die without other things, but if you don't do one particular thing, child will die. So allopurinol, okay, you if it is available you can start. Even if you don't start, no one will be will penalize you. Respirogase, okay, you can start if it is available, but even without respirogase, you can transfer the child. Blood transfusion is an optional thing. It all depends on how hemodynamically unstable the child is. Intravenous antibiotics might need, might not need, because if there's no fever, neutropenia per se doesn't need. But hyperhydration is the most important thing in any child with newly diagnosed malignancy because they are at risk of developing tumor lysis syndrome, TLS. That's a syndrome where you get because so usually this can happen at the beginning of chemotherapy because that's the time when we iatrogenically him kind of lysing the tumor or destroying the tumor. But sometimes tumors can itself go into spontaneous tumor lysis. So tumor lysis means lots of cell death is happening at the same time. So because of that, lots of uric acid is going to be produced and it is toxic to the renal parenchyma. So if you do not do hyperhydration, there will be definitely acute kidney injury. Right. Sixth one. A 9-year-old boy presents with limping on right side. This is very common. He gives a history of viral infection 2 weeks back. He has no fever. The right hip joint movements were restricted. His inflammatory markers were normal. What is the likely diagnosis? So, boy, 9 years, limping. So, all these presentations, I can give 5 best of 5 MCQs because I have put 5 answers. All these are possibilities of a child with limping. So, septic arthritis is unlikely because no fever, inflammatory marker, no. Osteomyelitis is unlikely because of the same reason. Slip upper femoral epiphysis possibility, but hardly anything given in the history to suggest slip upper femoral epiphysis. Like if this child is an obese child, obesity, and slip upper femoral epiphysis would be a likely reason in the absence of a viral infection and all. Transient synovitis is the likely diagnosis because child gives a history of viral infection 2 weeks back, but at the moment no fever. So highly likely this is transient synovitis of hip. Complete diagnosis would be that. And juvenile idiopathic arthritis usually do not occur in hips. So JI usually starts with knee joint, ankle joints, and small joints of the hands and feet. And if it is the case, inflammatory markers would be high. So that's not the case. Okay, then a 5-year-old boy was found to have isolated splenomegaly during routine abdominal examination. This is one of your short case, right? So you were given a case of an abdominal examination and then you found the child has got isolated splenomegaly without any hepatomegaly. But at the exam, you are not that confident to say no hepatomegaly. Because of that, someone might say, okay, maybe 1 centimeter, 2 centimeter, right? That is, so these kind of levers are palpable only for medical students. So, but in this case, clearly mentioned no hepatomegaly. So this is a very common short case. So he was born at 31 weeks of gestation and required NICU care for 3 weeks. So that is a clue here. So child with isolated splenomegaly could be due to hereditary spherocytosis, yes. Could be due to thalassemia as well, yes. Portal hypertension, yes. AML, yes. Visceral leishmaniasis, yes. But highly likely this is a case of portal hypertension because child had neonatal ICU care admission during the neonatal period, means child would have had umbilical venous catheterization. So, umbilical venous catheterization is a major risk factor for later development of portal vein thrombosis and subsequently portal hypertension. So that is why that part is given in the stem. Right. So these are not best of 5. Number 8 is not a best of 5 question, but I just wanted to give some input. So which of the following is not considered as a notifiable disease in Sri Lanka? It's a matter of going through the notifiable diseases list. So HIV is not a notifiable disease, but all the other diseases are notifiable. All the other diseases mentioned here. Right. Question number 9. Which of the following radiological features incorrectly paired with the given condition? So boot-shaped heart. That is the classical heart shape you see in tetralogy of factors. Achronocyte appearance is seen in transversion of great arteries. That you should know. Sale sign means you see the sign in the X-ray. So it's the thymic shadow you call sale sign. And snowman appearances means it's a case of total pulmonary venous drainage, TAP-VD. And cardiomegaly in pulmonary stenosis is not a feature because pulmonary stenosis is a condition where you get a reduced pulmonary blood flow. So that means You can't have cardiomegaly in pulmonary stenosis. So answer E. Right. In children, aspirin therapy is indicated in all conditions except. So aspirin is very rarely used in children except for few conditions. So I want to give this message to you all. These are the 4 occasions where we use aspirin in children. So 4 occasions are rheumatic carditis, juvenile idiopathic arthritis, Kawasaki disease. In these 3 conditions, we give high doses of aspirin or anti-inflammatory dose of aspirin. But in stroke, we give antiplatelet dose of aspirin, but we don't give aspirin in osteomyelitis, right? Because simple theory behind this is aspirin is not indicated as an antipyretic in children. All these other conditions, 3 conditions, we are giving aspirin as an anti-inflammatory agent, and in stroke we give it as an antiplatelet agent. So aspirin has 3 main actions: anti-inflammatory action, antipyretic action, antiplatelet action. Out of that, in children, we take only 2 actions into account when we give this medicine, because pyretic action is not used, not being used in children because they are at high risk of developing Ray's syndrome. That's a acute liver failure. Right, select the incorrect statement regarding childhood growth. So the maximum height velocity is seen during the pubertal growth spurt. That's false, because the maximum height velocity is seen in infancy. At birth, height is 50 centimeters, height or length, but about 1 year it's 75. So 25 centimeters of length gain is there within 1 year. But imagine, so at the age of 1 year, 75 centimeters, probably by about 15-16 years, it's about 150 centimeters. That means length at 1 year probably would have doubled. So what people say is usually the height at the age of 2 years. 2 times into height at the age of 2 years will be the final adult height. So if you're 165 centimeters, your length at the age of 2 years would have been 82.5 centimeters. Right? That's a general rule. All the other statements are correct. I wanted to give correct statements for you all to recap what you already know. Weight at birth is tripled at 1 year, doubled at probably around 3 to 4 years. Head circumference at birth is higher than the chest circumference. Yes, children have bigger head at birth compared to chest circumference. Average length at 1 year is 75 centimeters. Yes, that's true. Average head circumference at 3 years is 50 centimeters. That's true. In adults, it's around 55. At birth, it's 35. 35 to 55. So 35 to 50 until you get in adult age it's 55, right? About just around 50 to 57, 55 to 57 like. Right, a term baby, number 12, question number 12, a term baby, repeat, okay. So at birth, head circumference is 35. At the age of 1 year, head circumference is 47. So 12 centimeters of gain of height, head circumference within first year. So year 1 to year 3, only 3 centimeters gain. So 50 centimeters at the age of 3 years. In adults, you can measure your own head circumference. It will be around, okay, not clear. Can't you hear or you can't understand? Oh, height. Okay. Height at birth 50. At the age of 1 year, it's 75. So that means 25 centimeters gain in length within first year. And the second year, another 12.5 centimeters. So by about 2 years, the length is around 82.5. Oh, sorry. Yeah, 82.5. By about 4 years, height is around 100 centimeters. Right? So people say your final height will be the twice of your height at the age of 2 years. That's what I say. So if your final height is 160 centimeters, your length or height at the age of 2 years would have been 80 centimeters. Right? So it's I mean it's simple. So at the age of 2 years, your height is 80 centimeters now. Your final height may be around 160. It's a rough guide, right? It's important to know these rough measurements, but you should not be guided with all these things. You have to document or plot these things in the chart and interpret. Sometimes, in the absence of these charts, you should have some background knowledge. Right, okay. Question number 12. A term baby was born at term to a mother with gestational diabetes. So mom has got GT. He required resuscitation at birth due to birth asphyxia. It should have been an obstructed labor. Following successful resuscitation, he was taken to the NICU for further observation. So now the mom is in the labor room, baby was taken to the NICU. It's a very common scenario. What is the most appropriate intravenous fluid therapy for this baby until establishment of breastfeeding? So any newborn, within first 24 hours, we give 10% dextrose without anything added. However, there are occasions where we will have to add calcium into the 10% dextrose solution. One indication is gestational diabetes mellitus, another indication is birth asphyxia. Both these two indications are there in this chart. So the answer is C, 10% dextrose plus added calcium, but you don't need to add potassium or sodium until 48 hours. Right? So we are adding calcium here because of this history, otherwise answer would have been B. But here, in addition to 10% of dextrose, we will have to give some calcium because of the history of GTM and birth asphyxia. Right, a 3-year-old boy was investigated for polyuria and polydipsia. His investigations are as follows. Sodium high, potassium normal, or serum osmolality is high, urine osmolality is low. So usually the urine osmolality should be higher than serum osmolality. If serum osmolality is above 300 and urine osmolality is below 300, then you can diagnose diabetes insipidus. So if you go through these 5 answers, hypernatremic dehydration, okay, sodium is high. But in hypernatremic dehydration, how can you get polydipsia? Sorry, polyuria. So child is dehydrated, you can't have polyuria. So that's out. Diabetes mellitus, urine osmolality will be high in diabetes mellitus because you are losing lots of sugar in urine. So that's out. Psychogenic polydipsia is very common, probably the narrowest differential diagnosis would be that. But in psychogenic polydipsia, urine concentrating ability will be there. So 150 is not tally with psychogenic polyps. Diabetes insipidus is correct because that's a condition where you get high serum osmolality with low urine osmolality. Bartter syndrome can present with polyuria polydipsia, but they have low sodium and low potassium. So Bartter syndrome is a condition where you get metabolic alkalosis. Right, this is also kind of a MCQ, multiple choice type question. Which of the following condition presents in metabolic alkalosis in children? Hyperventilation can cause alkalosis, but it is respiratory alkalosis. Hyperaldosteronism means Conn syndrome. Yes, Conn syndrome means aldosterone is secreting in excess. So it can cause in the distal renal tubule and collecting ducts. So there can be exchange of bicarbonate together with potassium. So go back to your physiology, you will realize. And even without knowing that, salicylate poisoning is a condition. Children present with metabolic acidosis. Fanconi syndrome is a condition. Children present with metabolic acidosis. Acute kidney injury is also metabolic acidosis. So, three conditions: C, D, E, metabolic acidosis, hyperventilation, alkalosis, but respiratory. So, one condition is left. That's the correct answer. That is hyperaldosteronism. Right. So the last question, a 3-week-old baby was referred to the pediatric clinic in a tertiary care hospital with an abnormality detected in the newborn screen. This is very common scenario in teaching hospital karate where we do the newborn screening for the half of the country. The baby is thriving well and has no jaundice. Right? Heel prick TSH is 30, normal is 20. It's high but not that high. What's the most appropriate management? So I will show you an algorithm. Can you see this? So this is the national algorithm. I mean, it's not like this in the book, but I converted this into a flowchart line. So hypothyroidism, heel prick and venous. Because in some private hospitals still in Sri Lanka, they do venous T4 TSH at the age of 7 days. Not heel prick in private hospitals, certain private hospitals. So in venous blood, if low thyroxine is there, definitely you have to start treatment. You can have normal thyroxine with abnormally elevated TSH. In that case, if TSH is very high, above 20 with normal T4, yes, still start treatment. If these two, like not that high, but just above normal, like 6 to 20, then do the ultrasound scan of the neck. So that is not a very common scenario. Here on this side, it's the commonest scenario because most of the babies will get heel prick. So there can be three possibilities, right? So TSH can be less than 20, then parents will not be summoned or parents will not be called to come to a hospital and they will be given the label as, okay, your TSH report is normal. And if it is 20 to 40, then above 20, basically you can start treatment. But if you are in a tertiary care hospital with facilities available, if you can trace the report within next 24 hours, you don't need to start treatment If that is normal, you don't need to give treatment at all. If you report which was taken after 24 hours, so within 24 hours of the presentation, if it is also elevated, then treatment should be started. So this question is a bit tricky. What I have asked here is heel prick is 30. So if you are in a peripheral hospital, if you don't have a facility to trace T4 TSH venous blood within next 24 hours, please start on thyroxine. But if you can trace the report within 24 hours, that means you don't need to delay it. If you're not going to delay it, you can wait for 24 hours before starting treatment. So answers here would be A and C. You never reassure parents. You never repeat another heel prick to confirm. So the confirmation will only be with serum or blood liquid. And repeat the heel prick is never done. Reassure parents never. With starting of thyroxine or send venous blood. So out of that, the answer is A. If you can't chase the blood or trace the blood report within the next 24 hours, please start thyroxine and later on. But before starting thyroxine, you must send a sample. Otherwise, you will never be able to diagnose hypothyroidism in this child if you have not taken repeat venous sample before starting treatment. Right? So now only I can see some of these things in the chat. So pubic hair or axillary hair appears first. I don't know, probably both things appear together. You will not be questioned on that. Right? Papilledema doesn't diagnose the condition. Yes, but you can diagnose. Now, the diagnosis means diagnosis has different terms like histological diagnosis, pathological diagnosis, biochemical diagnosis, clinical diagnosis, lots of definitions. You can't say if papilledema doesn't diagnose conditions. Yes, you can diagnose clinical diagnosis, but you might not get a radiological or pathological diagnosis, right? So any child with features of increased intracranial pressure, examination of the funda is the key, right? Okay, can presence of papilledema diagnosed condition, is it only because of, okay, maybe a wording, there may be a problem in the wording. So can't it be stroke? Yes, but early morning headache, vomiting, so you don't get in stroke. In stroke, usually what you get is body weakness on one side. So in rheumatic carditis, aspirin or steroids, it's aspirin always, provided that the child has not gone into cardiac failure. So rheumatic carditis can present in two ways, with cardiac failure, without cardiac. If it is cardiac failure, of course steroids. If not, aspirin. What we usually see is rheumatic carditis without heart failure. Sir, can you please repeat the height story? I think I have done it. Can you please say about the average marks? Unfortunately, I can't see that. I am also keen on getting to know that. Cerebellar signs could be diagnostic here, sir. Okay, there may be a problem in this question because of lots of these confusion. So we don't have any scrutiny to help when we make our own questions. Um, but anyway, yeah, I agree. Cerebellar signs could be diagnostic here, but lots of conditions can give rise to cerebellar signs. In a child with headache, nausea, vomiting, cerebellar signs could be due to lots of things. Agree, papilledema also could be due to lots of things. But all these things are features of increase intracranial pressure. That's why. No different entities. But cerebellar signs could be due to drug intoxication. So and could be due to um, posterior fossa tumors, right? So that's all. So at birth, TSH level surge is there. Yes, there's slightly elevated amount of TSH is there around birth. That's why we have a bit of a high value for screening. So according to that chart, venous blood also taken for newborn. That's what I said, for newborn screening in private hospitals. They are not bound to do this heel prick test. So if you can do venous blood in 7 days time, that is better than heel prick test. But the problem is we can't recall all newborns at the age of 7 days to the hospitals. We might lose these babies to follow up. That's why we do heel prick testing just before they go home, right? So when you plan a newborn screening, you have to look into practical aspects as well. Fredrickson ataxia and child ataxia. Fredrickson ataxia is a differential diagnosis, but don't even think about it. So what's the use of rasburin? So rasburicase and allopurinol, if you go through the pharmacology notes, so what allopurinol does is prevent formation of uric acid. Rasburicase blocks the next step, which I can't remember now. So both these are medications used in the management of tumor lysis syndrome. So ideal scenario, you have to start these children on allopurinol and hyperhydration both before sending to Maharaga. In pulmonary stenosis, can right ventricular hypertension? No. Cardiomegaly, you don't call ventricular hypertrophies into cardio. Usually in X-rays, cardiomegalies are seen due to dilatation rather than hypertrophy. It's very rare in even critical pulmonary stenosis. What you get is pulmonary oligemia. Because of that, heart will be shrunken, right? If more than 40 are still 2 T4 within 12. No, it says, let's go back. I can't see it. Yes, even above 40, it's important to repeat a venous sample. Keep that in your mind, right? So, because this is a highly sensitive test, but no specificity. So that's why you can have lots of false positive results, positively taken as hypothyroid, but it's not the case, right? So because of that, even if it is above 40, so whatever but we never do it with 100 of, usually if it is 100, still we have to repeat venous T4, TSH, but you don't need to wait. You don't need even to wait for more than 1 day. If it is our threshold is around 40 to 50, like, okay, we will do like this, but probably around 60, 70, 100. Most of the time, if there's thyroid agenesis, it will be around 100, right? Uh, right, that's it. But waiting for 7 days, okay, yes. Huge cardiomegaly, lung feeds, dilated right ventricular outflow. The classic appearance of pulmonary stenosis in heart failure, and it's difficult to distinguish from chronic pericardial lesion, but chronic condition of pulmonary veins suggestive of uh, okay. This is maybe extreme cases. That's why I always say, so you can have, but now you know in tetralogy of Fallot's pulmonary stenosis is there. I mean, so in MCQ sometimes, no, in that particular MCQ, if I go to that MCQ, I agree with what you have given. So there are conditions. Right, in that particular MCQ, there's no other alternative as well. So other things are very well. Boot shape heart is tetralogy were very well known. Neck on the side transposition were very well known. Sail sign is thymic shadow very well known. Snowman appearance in tap PD very well known. But cardiomegaly in pulmonary embolism may be a very rare condition. Usually, I don't know. At your level, what you need to know is any condition with reduced pulmonary blood flow. Any condition with reduced pulmonary blood flow, lungs will be oligemic with relatively small. We expect heart to be bigger, but not that large, right? Uh, yeah. Is there? So, but waiting for 7 days, okay? Yes. No, no. Without treatment for 7 days doesn't harm, sir. Now, do you think when do you get this heel prick testing result? Do you think you get it on the same day? You get it after probably 3 weeks. So 2 to 3 all over the world, that's the time period, right? So 7, if you do it on a 7 day in a private hospital, they will get that result on that day. So those who get testing done on day 7 will get the result on the same day, but those who got the testing on the just before discharge will get, because parents will get it through post, right? It all. So our target is to do this before 3 weeks, right? So you should not argue it with the timing of the test, but you should argue it with the timing of getting the test result. Is there any indication to start thyroxine in heel prick TSH? No. You should never start thyroxine just only based on heel prick test without sending venous sample, because you will never be able to diagnose this child in your lifetime whether the child is hypothyroid or not, because you can't stop thyroxine to diagnose condition if you have already started. Right. Okay. Any more classes? What else do you need? Like, you can speak. I will give only 5 minutes. Any suggestions? Short cases, short cases. So how can we do that? Is it you mean uh, for another MCQ business as a discussion like your clinical picture and short case discussion SCQ? So you want me to sit for the exam, it seems, on behalf of your how to present short cases. Okay, so you are going to come on 8 for your short cases. Uh, so that means 8th of February. Okay, I think short cases are the most after clinicals. Please do essay discussion. Yes, I can do that. Uh, yeah, I will arrange a short case. I don't know how to do that, but anyway, I will think. Probably I will give a scenario like and how to. I'll be mainly focusing on how to present. Right, that is the most difficult part for you, and you can follow all the steps of these examination with your colleagues in hostels and wherever the place. Right. So in pediatrics also nothing significantly different. Please notice about the dress code. Whose dress code? Maybe a demonstration. Uh, maybe a demonstration. Oh right, dress code of yours. Okay, I thought you all are worried about my dress code. Uh, oh, I don't know about this dress code. Anyway, I will make it a point and discuss with others. So probably you will have to come the way you came for your clinicals. I mean, clinical appointments. I don't know. Anyway, that part we will definitely inform you. Probably in the next week, uh, I'll arrange a short case class. It might not be practical for me to do a demonstration because the physical science and all, what because the steps. So there are videos in I don't know whether you'll have it or not in the Colombo Medical Faculty. There are sets of videos on system examination, 3 videos on CNS. Uh, so we are poor at presenting. I know that. Uh, so you have to practice. You can't say we are poor and just coming without any practicing at home. Right? You will have to go in front of a mirror and start practicing. And sometimes you will have to imagine your short case. Yes, Prof. Shamsa's videos. No specific pediatric. Even for my postgraduate exams, what I referred was this Prof. Sham Fernando's videos. Where they will give you the basic fundamental steps, right? So CNS neurology, CNS 3, cardiology, respiratory, abdominal. That's enough. So it's just following the steps plus techniques. In pediatrics, sometimes the steps can be kind of shuffled. Depends on the condition of the child. How if the child is a difficult customer, you can always alter the sequence. But if it's usually in your exam, cardiovascular system examination, we will give you bigger children most of the time. Right? It's not. Don't expect neonates or very little babies in because you will be given little babies for your developmental assessment and all. Right? I will do a short case class. Probably I'll let you know. Right? Uh, Yeah, short case class including developmental assessment. That is something very easy to perform. Developmental assessment, you don't need to do anything. It's a matter of just giving a running commentary. It has short cases. It helps to present it now. Diplomatic. Wow. Next week, maybe demonstrations. Okay, I'll stop it now. Right? I have to see the vote now. Okay, I'll send you a link. I have Batchrep's email address and contact details. So probably next week I will do a short case class, right? Okay, thank you.